Welcome everyone to our medical series that we have been doing during this time of COVID. We are focusing on all things health related right now, and today we have some special guests from Overlake Medical Center. I would love to introduce Dr. April Phantana-angkool, specializing in breast surgery for Overlake Medical. She is board certified by the American Board of Surgery, and her philosophy of care is that every patient is unique. She believes that the best approach to diagnosis of breast cancer is a collaborative partnership with a patient and all available breast cancer specialties to achieve compassionate and individualized treatment plan. Through honest discussion and tailored education, it is her hope to empower her patients in all aspects of their medical care to help achieve their personal goals. Thank you so much for being here with us today, and take it away, Doctor.
Thank you so much for having me today. Today, what I hope to accomplish is to share with you about some information about breast cancer, and just to make it such a mystery for all the women and men. Our objective today is just to give a nice review on breast cancer, go over screening, talk about breast cancer treatment a little bit. We're going to concentrate on the surgical management of breast cancer, and we'll talk about risk reduction strategies as well. Breast cancer is the most common type of cancer diagnosed in women. It is the second leading cause of cancer death next to lung cancer. 1 in 8 women, or 12%, will develop invasive breast cancer at some point in her life. This year, it's estimated that among the US women, there will be over 260,000 new cases of invasive cancer in women and 2,600 cases in men. Over 41,000 women and 500 men are expected to die from breast cancer this year. And to give you a better comparison, when we compare breast cancer death rate to lung cancer, the expected death rate for lung cancer is around 140,000 for this year. Fortunately, the death rate has been on the decline over the past 15 years, and this is due to the improvements in early detection and treatment. This figure demonstrates the trends and incidence rates of DCIS and invasive cancer from 1975 to 2016. We'll concentrate on the dark pink line, which represents women aged 50 or older. So we'll look at the left side here. From 1982 to year 2000, you can see a sharp increase in diagnosis of DCIS. And this is because more women were getting screened. Mammogram became more readily available for all women. If we turn our attention to the right side, you can see a drop from the year since 2001. So there's a decline here. And this was attributed to the study by the WHI, who published that hormone replacement therapy can cause breast cancer. So a lot of doctors at that time stopped prescribing hormone replacement therapy. We don't know the cause of most breast cancers. Most likely the cause is related to changes in the genetic material in our cells. These changes are often related to age, environmental factors, our lifestyle, and other unknown factors. Risk factors are anything that can increase or decrease a person's chance of getting cancer. So there are many risk factors for breast cancer. Some of these cannot be changed, but some can. It's estimated that about 1/3 of postmenopausal breast cancers are linked to potentially modifiable factors, including postmenopausal obesity, physical activity, use of hormone replacement therapy, alcohol consumption, and not breastfeeding. Researchers have identified hormonal, lifestyle, and environmental factors that may increase your risk of breast cancer. But it's not clear why some people who have no risk factors develop cancer, yet others with risk factors never do. It's likely that breast cancer is caused by a complex interaction of your genetic makeup and your environment. About 5 to 10% of breast cancer are linked to gene mutations passed through generations of a family. Breast cancer typically has no symptoms when the tumor is small and most easily treated, which is why screening is most important for early detection. There are many signs of breast cancer when they become larger. The most common physical sign is a painless lump. Other signs may include nipple retraction, dimpling of the skin, bloody or clear nipple discharge, redness or rash of the breast skin, or thickening of the skin. It would be safe to say that if you notice anything differently with your breast, that you should talk to your doctor about it. Breast cancer is typically detected either during screening, before symptoms have developed, or after a woman notices a lump. Your doctor or you yourself may find a mass during a clinical breast exam or during a self-breast examination. I would say the self-breast examination is important. You should do this monthly. This is best performed in 2 different positions, while you're standing and while you're lying down. I usually will ask my patients to do this in the shower while they're standing up and then while they're in bed lying down. You should also look in the mirror every now and then to see if the shape of your breast has changed any. In terms of screening guidelines, more than 4 international medical societies, including American College of Surgeons, American College of Radiology, and OBGYN, recommend annual screening mammogram beginning at the age of 40 for women of average risk. You'll hear me say this often throughout this presentation, that breast cancer typically produces no symptoms when the tumor is small and is most easily treated, which is why screening is important for early detection. Some of my older patients will ask whether screening mammograms should be continued over the age of 70. The American Cancer Society states that women should continue screening as long as their overall health is good and that they have a life expectancy of 10 years or longer. Screening has been proven to save lives in multiple large studies, mainly by detecting cancer at a very early stage. Mammogram can detect masses as small as 6 millimeter or 1/4 of an inch, and MRI as small as 3 to 4 millimeters. Masses are not often palpable until they're over an inch in size. When you receive your mammogram, it can be either in 2D or 3D. The standard is usually 2D. Most cancer centers and most imaging centers are switching over to 3D tomosynthesis. 3D mammogram is useful in women with dense breast tissue. The 2 pictures shown on the right side are from the same patient. So you can see that with the 3D, you can see the mass a little bit better. You should talk to your doctor or a breast specialist about what screening modality is best for you. There are also supplemental screening modalities for women who are considered high risk. Most cancer centers now offer 3D, like I said, but some will also offer ultrasound and breast MRI. Breast MRIs usually cover if your lifetime risk of getting breast cancer is over 20%. Anything below that, insurance unfortunately won't cover it. Breast tissue density is an indicator of the amount of glandular and connective tissue relative to fatty tissue measured during a mammogram. Following a mammogram, radiologists categorize a woman's breast tissue according to the standardized system developed by the American College of Radiology. Women with dense breasts have a 1.5 to 2-fold increased risk of breast cancer compared to those with average density. So an average density would consider to be a scattered area of fibroglandular density. It's the second picture here. And anything that's denser would be this 3rd one and the 4th one. And as you can see, dense breasts tend to show up as white, whereas the fatty tissue tends to be gray. An abnormality normally would show up as white, and that's why it's difficult to see, or maybe difficult to see if you have dense breast tissue. Currently, there are 38 states, including DC, requiring some level of breast density notification after a mammogram. If you've had a mammogram in the past, you may see a statement similar to what's listed here on the screen attaching to the bottom of your mammogram report. You should talk to your doctor about your risk, especially if you have family history of breast cancer. I've mentioned supplemental screening before, but supplemental screening may include an ultrasound or an MRI. An MRI is typically recommended if your risk is greater than 20% compared to the general population. The lifetime risk is calculated using risk assessment calculator that is largely based on your family history. And so in our high-risk clinic, we offer to evaluate women and men who may be at high risk for breast cancer. During that visit, we will calculate your risk and discuss screening modalities that's best appropriate for you. These are mammographic and sonographic images of breast cancer. Breast cancer may show up as a mass, as this up here on the screen. It may show up as calcifications, which are white speckles on imaging here. It may also show up as an architectural distortion where the tissue appears distorted on mammogram here. Or it may show up on an ultrasound. The bottom right picture is an image of a breast cancer found on ultrasound. When cancer is suspected on imaging, tissue for microscopic analysis is usually obtained from a needle biopsy and less often from a surgical biopsy. This is because image-guided biopsy is much less invasive. And biopsy may be guided by a mammogram, also known as stereotactic biopsy, by an ultrasound, or by an MRI. The method is chosen based on the size of the tumor and how it was found in the first place. If you look at the picture on the left side, this is an example of what a stereotactic biopsy looks like. A woman will lie facing down and the breast will drop into this box. The radiologist will then identify the mass or the suspicious finding on mammogram again. They will numb up the skin using some local anesthetic and then insert the biopsy needle into the breast and obtain several core biopsy from this area. Similarly, with an ultrasound, the area of concern is identified under ultrasound guidance. The skin is numb with a local anesthetic, the needle is inserted into the breast, and a biopsy is obtained. Current breast cancer care typically consists of a multidisciplinary approach combining the expertise of oncologic surgeons, plastic surgeons, radiologists, medical oncologists, pathologists, and the radiation oncologist. We're able to obtain the best outcome when we treat it in a multidisciplinary fashion using surgery, radiation therapy, and systemic therapy. Depending on the patient stage and the type of breast cancer at presentation, they will have one or even all three therapies. Local treatment, surgery and radiation means treating the breast and the axilla. This is to remove the cancer, assess the lymph node in the armpit, and reduce the chance of cancer coming back locally in the breast or the chest region. Systemic therapy is a whole body therapy. This is given to treat and or to prevent cancer from recurring anywhere else in the body. It comes in many forms, including chemotherapy, immunotherapy, targeted therapy, and anti-hormone therapy. If you were to ask two breast cancer survivors about their treatment, you may find that they had received completely different treatments. Why is breast cancer treatment so personalized? The type of cancer that she had may affect the treatment. And it's because not all breast cancers are the same. And so treatment recommendation may be different from one person to another. All of these factors listed up on the slide may change surgical management, radiation treatment, and whether chemotherapy or anti-estrogen therapy is needed. Surgical options have advanced significantly over the last 150 years. Since the first description of breast tumor over 3,000 years ago, anatomical and surgical techniques in the field of breast surgery have undergone an enormous amount of innovation. The earliest report of breast cancer are found in the Egyptian text dating back to 3000 to 2500 BC. Hippocrates, who was a Greek physician and scientist, proposed a theory attributing the cause of cancer to having excessive black bile. He described tumors as having many legs extending from the main mass, calling it karkinos, which is known as crab in Greek. This is also an origination from the word carcinoma known today. Galen came in later and expounded upon this theory further, and he thought that cancer was caused from coagulation of black bile. He used the term oncos, which means swelling in Greek, to describe tumors. He recommended resection of the tumor, and for the next 1500 years, this was the common theory that doctors used. Surgery at that time was very morbid, disfiguring, painful, because there was no anesthesia and there was no aseptic techniques. The picture on the right represents an instrument that was invented by a German physician. And the goal of this instrument was to remove the breast and the tumor in the shortest amount of time. Needless to say, the patients did not tolerate this very well. The 19th century dramatically changed the field of surgery when anesthesia and aseptic techniques were developed. Until the late 1890s, breast cancer was a fatal disease. William Halstead, who was an American surgeon, challenged this by performing aggressive surgery to achieve control. In 1894, he published the Johns Hopkins Hospital experience with the radical mastectomy. This involved removing the breast with the chest wall muscle and a lot of lymph nodes. Women were very disfigured following this procedure, had chronic pain, arm swelling, and some were not able to move their shoulder. Around that time in Russia, physicists began treating cancer with radiation and had good results. But since no one knew the long-term of the outcome of radiation potential side effects, this aggressive surgery remained a standard of care well into the 1970s. By that time, several European physicians began to perform less aggressive surgery utilizing radiation as well. Betty Ford was diagnosed with breast cancer in 1974. She actually had undergone a radical mastectomy at that time. At that time, the diagnosis to surgery was very brief. Often biopsy was an open procedure in the operating room. There were no stereotactic or image-guided biopsy. The women would sign consents to have a biopsy and then a mastectomy. If a biopsy showed cancer at that time, then the surgeon would move forward with the mastectomy. As a result, women often enter the operating room without knowing whether she would have her breast or not. Betty Ford was one of the first public figures who came out and spoke openly about her experience with breast cancer. At the time, discussing cancer, especially breast cancer, was very taboo. By the 1940s and 1970s, many surgeons were questioning whether disfiguring radical mastectomy procedure was necessary. Many began to perform modified radical mastectomy, which entails removal of the whole breast, the axillary lymph nodes, and the pectoralis muscle was not included. In the 1960s, a few doctors began promoting the idea that less extensive surgery might be as effective as a radical mastectomy. And in 1971, the National Surgical Adjuvant Breast and Bowel Project, also known as NSABP, began enrolling women in a study comparing the effectiveness of radical mastectomy versus simple mastectomy where just the breast was removed. And this was given with or without radiation. The study eventually showed that all three treatments were equally effective. Today, thankfully, there are virtually no indications for radical mastectomy. Patients with involvement of the chest wall muscles should get chemotherapy first. Chest wall resection is rarely performed nowadays because screening has become so well known and well used. This is a picture of a woman who underwent a total mastectomy. This is where the breast is removed and the majority of the skin, and also including the nipple and areola. We typically will use this procedure if the woman does not desire breast reconstruction afterwards. Some patients still require mastectomy, so we have developed techniques to improve cosmesis. And this is an example of a skin-sparing mastectomy where we leave the majority of the skin but take the nipple areolar complex. The procedure is followed by a breast reconstruction performed by a breast surgeon or a breast plastic surgeon. These are representative pictures of a patient who underwent nipple-sparing mastectomy. A nipple-sparing mastectomy is where we remove the breast tissue but keep the envelope of the breast. The procedure is followed again by reconstructive plastic surgery. This is the before picture, and this is the after picture. To further minimize the extent of surgery, several investigators evaluated lumpectomy. The procedure involves removal of the tumor with surrounding health tissue. In 1976, the NSADP launched the B6 trial, which would later show that lumpectomy followed by radiation was just as effective as a mastectomy. So nowadays, women with small tumors have the choice of undergoing a lumpectomy. A lumpectomy is an outpatient procedure. You get to go home on the same day, whereas a mastectomy may require a one night or an overnight stay. You may ask, what if you can't feel the tumor? Because this is typically picked up by a screening mammogram. How do we find it? Typically what happens is a radiologist will identify the tumor for the surgeon. They will then insert a wire. Think of it as a toothpick going into an olive. The surgeon then will put the patient will go to sleep under anesthesia. We then make a small incision and then remove the cancer with a good rim of healthy tissue surrounding it. The wire will come out along with that. Another localization technique is called a Savi Scout, which uses radar technology to guide surgeon to precisely target the breast tissue during a lumpectomy. And in this middle picture here, you can see the Savi Scout reflector here that was placed next to the biopsy marker clip here. And then again, we make a small incision and then remove the tumor with a good rim of healthy tissue around it. The Savi Scout reflector can be placed several days, even months before surgery. One of the most common questions that I get asked is, how do we know that we got it all? Well, we look for a margin. This is performed by a pathologist where they look at the rim of the submitted tissue for cancer. So under the microscope, you can see that this is the edge of the tumor, and then you can see cancer marching up to here. And the margins here would be considered to be 2 millimeters, whereas in this image, it's less than 1 millimeter. Increasing margin width does not decrease local recurrence rate. This has been shown in many studies. About 80 to 90% of the time, we are able to get all the cancer during the first operation. About 10 to 20% of the time, it does require for a patient to go back for a re-excision of margins, and sometimes a mastectomy is required. Cancer can spread to the lymph nodes, so we need to check the lymph nodes by performing a sentinel lymph node biopsy or an axillary lymph node dissection if you were diagnosed with an invasive carcinoma. The procedure is formed during the lumpectomy or a mastectomy. It would be very rare that surgeons would proceed with an axillary lymph node dissection as the first option, given that the patient was clinically negative in the first place. A sentinel lymph node biopsy is sometimes the blue dye will also be used as well. The dyes will then travel through the lymphatics and then stay in the forefront lymph nodes, or known as the sentinel lymph nodes. The surgeon will then identify anything that's radioactive or anything that's blue and remove those lymph nodes. The lymph nodes will then get submitted to the pathologist, and then they will evaluate whether there's any cancer in the lymph nodes or not. The procedure allows us to provide more prognostic factors for the patient, and it also allows us to have more information about how to best treat this cancer. An axillary lymph node dissection is a procedure where we remove the fatty tissue underneath the armpit. We remove the lymph nodes that's in the level 1 and level 2 zone. Many lymph nodes are found in this area. The procedure may be performed for those with locally advanced disease or those who may have clinically who are clinically node positive, who did not wish to undergo chemotherapy. Approximately 30 to 40% of patients will develop lymphedema or swelling of the arm in this procedure. And so most of the time we will elect to perform a sentinel lymph node biopsy first, because the risk of lymphedema associated with a sentinel lymph node biopsy is around 5 to 8%. Radiation therapy has been shown to decrease local recurrence by 2/3. It works by eradicating cancer cells that may have been left in the breast. Of note, it only treats the breast and the regional lymph nodes. Typically, this is recommended following the surgical procedures such as a lumpectomy. In some patients who had a mastectomy, they may require radiation as well. And this is dependent on how large the tumor was in the first place and whether there's any lymph node involvement. As stated before, radiation reduces the local recurrence by 2/3. It's recommended in women who were wanting to undergo breast conservation surgery. The side effects of radiation may include fatigue, skin changes, or skin burn. It may also cause skin indentation where the surgery was performed. It's been shown to be safe for the heart and lungs. Patients who are not candidate for a lumpectomy are usually the ones who'd had radiation in the past, who breast cancer that was diagnosed early in pregnancy, and women who have diffuse or widespread disease. There are some relative contraindications as well that are listed here. This is an example of a skin indentation following a radiation treatment and a lumpectomy. The improvement of survival trend has mirrored improvement in quality of life. While disease control remains the primary aim of breast cancer treatment, improved aesthetic outcomes by reconstruction continues to positively impact patients' lives after tumor removal. Oncoplastic surgery uses plastic surgical techniques to improve cosmetic outcomes in breast conservation surgery. In breast conserving surgery, a conflict exists between a wide enough resection to obtain optimal oncological outcome and not removing so much breast tissue as to leave a deformed or asymmetric breast. This procedure has emerged as a new approach for extending breast conserving surgery possibilities, potentially reducing both mastectomy and re-excision rates while avoiding breast deformities. We have come a long way with different incisions and small tissue rearrangements that have a better cosmetic outcome. That being said, the biggest priority is cancer resection following cosmesis. These are examples of extreme cases. The patient up here actually had disease that spans about 90 millimeters. She did not want to undergo a mastectomy, and she was able to undergo a large lumpectomy followed by breast reduction. Similarly, with this patient, she also had a very extensive disease and did not wish to undergo a mastectomy. So she also had a very large lumpectomy as well, and then underwent bilateral mastopexy and reduction. There are many options for breast reconstructions. The picture here on the left side is an example of what a tissue expander looks like. Typically, following a mastectomy, a plastic surgeon will insert a tissue expander in there in place of, rather than a real implant as the first step. This is because we want to make sure that all the cancer is gone. So we need to confirm that we are done with the oncologic procedure. Several months later, the implant may be placed afterwards. There are more options for breast reconstruction in addition to using breast implants. These include using a tram flap that includes the fatty tissue and the muscle from the abdomen, or using the fatty flap from the abdomen itself, which is called a deep flap. The back muscle may also be rotated in to help with reconstruction in conjunction with an implant as well, and this is called a tissueless flap. These procedures are performed by a plastic surgeon. The most common questions that get asked is, which one is better? For average risk women, there is no difference in overall survival for mastectomy versus lumpectomy. Given that patients who underwent a lumpectomy also undergo radiation and the anti-hormone estrogen pill if she has ER-positive disease. The rate of local recurrence in women who undergo breast conservation therapy is around 3 to 4% in the next 10 to 15 years. If you look at the mastectomy rate of local recurrence, it's around 2 to 3% in the next 10 to 15 years. So I always tell my patients that the risk of recurrence is not zero with a mastectomy. And if you compare the two rates on both sides here, the absolute difference is 1%. Contralateral prophylactic mastectomy is where we remove the breast tissue on the unaffected side. Women who have gene mutations such as BRCA1 or BRCA2 may consider this option. Angelina Jolie actually had popularized this concept of prophylactic mastectomy. Her mom was diagnosed with ovarian cancer and underwent genetic testing and was found to have BRCA mutation. Angelina Jolie herself underwent genetic testing and also was found to have a BRCA mutation. And so she elected to have bilateral mastectomy, prophylactic mastectomy. The chance of getting breast cancer in women who have BRCA mutation is above 70% in her lifetime. Women who underwent mantle radiation to the chest in their childhood also have the option of undergoing this procedure as well. This procedure has shown no benefit for women who are of average risk. So what can you do to reduce your risk of getting breast cancer? This is a list of what you can do to minimize your risk. First, limit alcohol intake, 1 drink a day. A drink is considered to be 12 ounces of beer, 5 ounces of wine, and 1.5 ounces of liquor. Avoid smoking. Cigarettes and tobacco are well-known carcinogens. Controlling your weight, keeping your weight low to a BMI of less than 25. Exercising has also been shown to be a risk reduction. Exercising 30 minutes a day, 5 days a week, something to keep your heart rate up, has been shown to be a risk reduction. And limiting hormone replacement therapy use to less than 3 to 5 years has also been shown to reduce your risk. What I want for you all to take home today is that early detection decreases breast cancer mortality, and that you should see your doctor if you ever feel anything differently or feel a lump in your breast. Again, breast cancer is typically painless. It may present as a painless lump. Although breast cancer treatment has advanced significantly over the past few years, we still have a lot of work to do. I would encourage you all to participate in clinical trials if you're able to. And we also need to keep in mind that we need to include men in many of these clinical trials and studies. And I will take any questions at this time.
Sorry, I'm trying to unmute myself here. Any questions? This is a lot of great information. Thank you so much.
And it is a lot of information, but what I hope that everyone takes home today is just that get your screening. If you haven't had your screening today or this year, I would encourage you all to do that. If you've had your screening mammogram already, then ask a friend if they've had theirs and encourage them to go get one.
Great. I see one question has come up. Can you describe HRT a little bit more?
Hormone replacement therapy is typically utilized in women who had undergone menopause symptoms or menopause. It's used to help out with hot flashes, mood swings, and things like that. It's also been shown to help with the cardiovascular side effects. So women who undergo early menopause have an increased cardiovascular risk, also increased risk of developing dementia, and hormone replacement therapy has been shown to reduce these risks. So we must balance this with getting breast cancer as well.
Okay. And another one that just came into me, does that include people who take just progesterone?
Yes, that would include that. So hormone replacement therapy actually comes in many forms. It can be progesterone only therapy, estrogen only therapy, or combined therapy. Recent studies have shown that estrogen only therapy has been shown to have a rather reduced risk when compared to a combined hormone replacement therapy. And so in our patients who had BRCA mutation, who had to undergo oophorectomy, where they're getting surgically induced menopause, will be placed on hormone replacement therapy. It's encouraged for them to just go on an estrogen only therapy.
Okay, and what about birth control pills and the risk for breast cancer?
Well, that's a great question. Birth control pills has been shown to increase your risk by just a little bit. It's shown that in every 8,000 women who take birth control pills, one woman will develop breast cancer from that. So that just shows you the relative risk of that. Overall, from the medical profession, it's considered to be safe to take birth control pills because we do not want an unwanted pregnancy. And also the risk is quite small. It is there, but it's quite small.
Great, thank you. And one more, for women who have dense breasts, you mentioned that it can be harder to detect. What extra special precautions can women take who have dense breast tissue?
So I think if you have an average risk of developing breast cancer, and that would mean that you have no family history and that you have dense breast tissue, you have the option of undergoing additional supplemental screening, such as an ultrasound. Some imaging center will do a mammogram and a breast ultrasound at the same time. Some will not do that. And so if you are worried about getting breast cancer in the setting of dense breast tissue, then you should talk to your doctor about whether an ultrasound would be needed for you or appropriate for you. But having dense breast tissue, essentially, it makes it difficult for the radiologist to see. And so one way to kind of improve the images a little bit is by asking whether you're getting a 3D tomosynthesis with your mammography. And I would say most imaging center has converted to just doing a 3D tomosynthesis, but there are some imaging center who are still just doing the two-dimensional or 2D mammography. And so 3D has been shown to improve the detection rate a little bit because they're able to twist the images around to see each layer a little bit better. And so I would say the supplemental screening imaging is certainly not for everyone, but that's something that you should discuss with your doctor. It's certainly very personalized, and it varies from one person to another, and it's different because of your family history, your risk, as stated in the slides. And so we use a lot of things to kind of help us determine what's best for you.
Okay. So all the questions I've seen come in to me. Anyone else on the Zoom call have any other questions? Okay, well, thank you so much for your time today. Thank you for this really important information during Breast Cancer Awareness Month. We really appreciate you being here with us today.
Thank you so much for having me. I appreciate it.
All right, thanks. Bye-bye, everybody.